Hawaii needs 300 primary care doctors statewide, according to an annual report evaluating the island's growing doctor shortage. More than 500 specialty doctors are also needed. The shortage is bigger on the neighbor islands, especially on the Big Island, where the number is 44%. Why is this happening, and what's being done to stop it? Tonight's live broadcast and live stream of insights on PBS Hawai'i start now.
Aloha and welcome to Insights on PBS Hawaii. I'm Daryl Huff. There are several factors that contribute to the declining number of practicing physicians in our state. A fourth of our physicians are more than 60 years old, not that there's anything wrong with that, and heading for retirement or semi-retirement. Some find the added red tape and electronic records requirements and insurance oversight just overwhelming. Younger docs with high student debt are attracted to the mainland, where they can earn more and enjoy a lower cost of living. A report submitted to the legislature in December shows Hawaii's woefully short of primary care doctors as well as certain specialists. Our panel tonight includes 3 physicians, including the author of that report, a neighbor island doctor, and a medical student. We all look forward to your participation in tonight's show. You can email, call, or tweet your questions, and you'll find a live stream of this program at pbshawaii.org and the PBS Hawaii Facebook page. Now to our guests. Dr. Kelly Withey is a professor of family medicine and community health at the University of Hawaii Medical School. She earned her medical degree at UC San Diego and a PhD in biomedical sciences from UH Manoa. She's the principal investigator of the Hawaii Physician Workforce Report. Dr. Rick Bruno is an emergency physician at the Queens Medical Center and a vice president there. He earned his medical degree at Yale University. He and his family moved to Hawaii in 2004. He says he hikes on weekends and teaches CrossFit at a friend's gym. Dr. Michelle Mitchell is a graduate of the UH Med School and has been practicing family medicine on the Big Island for more than 11 years. She is a clinical instructor for multiple schools here and on the mainland. And Claire Marie Anderson grew up on Molokai and Oahu. She's a second-year medical student at the John A. Burns School of Medicine, where she is the co-president of the Rural Health Interest Group on campus. Let me start with you, Dr. Mitchell. You're sort of in the center of this storm of physician shortages. Can you tell me a little bit about what it's like working in Hilo when there's so few other doctors around to support you? And I think you told me earlier that you used to have 3 doctors working with you.
Well, we used to be a team of 3 in my practice when I first started about 12 years ago, and now it's just me. I'm the last man standing. It's, in one word, stressful. You know, I'm watching my community not get the health care they need. You know, my neighbors, my family, my friends, and I'm watching people not be able to access physicians because they're just not available, mostly primary care, which is really sad. I'm taking on a lot of new patients in spite of the fact that I already have a panel of 2,000 patients. So that's more than a single physician can handle, but I have a good support staff and an excellent team, which helps me handle more patients. But unfortunately, not all solo physicians have that. So that means that patients are just not able to access care, and it becomes dangerous.
You know, when you always hear about Hilo, like I think when Mayor Kim had a heart attack, he had to fly. What kind of things happen that are very common that you actually have to send people to Oahu or another island?
Well, we have to send people out for anything we don't have access to, like subspecialists or some specialists. We don't have rheumatology available. We don't have endocrinology. We don't have a lot of different subspecialists for surgical. But when you have a good base in primary care, like our family medicine training, when we did our training here on Oahu, we did emergency medicine, like I did with Dr. Bruno. Thank you. And when we did our training here, I did the ICU, the NICU, we did obstetrics, gynecology. So we get a really good basis. We can do a lot in primary care and family medicine and internal medicine, and that helps us give a good base so we don't refer as often.
Dr. Bruno, tell me what you're seeing from your perspective is the biggest impact of this shortage.
Sure. I wear 2 hats at Queens. In the clinical arena, I'm an emergency physician. I work in the punch bowl ER. And from that lens, we get approximately 10,000 requests a year from other acute care facilities to transfer patients in because they don't have the services. And a lot of times, as Michelle says, they don't have the specialist. And so at Queens, we're committed to taking care of everybody. And so in the emergency room, not only do we take care of the folks in Oahu, is we receive a fair number of acute care transfers from the neighbor islands because of lack of services. On my administrative side, I help manage the employed physician group, and I think a lot of what Dr. Withy has talked about is we have those same issues as far as lack of primary care. Our aging workforce is the issue of similar numbers at Queens. About 25 to 30% of our active medical staff is over the age of 65, and those are the same folks who take call every third night to take care of patients. And that's one of the challenges, keeping our call schedules together, making sure we have people to take care of our patients.
Kelly Withy with the medical school, and you do this survey. Where are the worst places, where are the worst situation for the shortage in the state of Hawaii? Is there places it's worse than other places?
Big Island. All the neighbor islands are worse than Oahu in most things, and Big Island is by far the worst.
I think we have a graphic that we can talk about. So on Oahu, it shows 377 doctors short, 16% short of what it should be. Big Island, 230 doctors short, 44% short of what it should be. Maui County, 36%. Kauai County, 24%. Statewide, 24% short, 820 doctors short. How do we get to that figure? I mean, how do we know the right number of doctors?
We actually don't.
Oh.
So the demand number is based on the average utilization of doctors throughout the country. So what we're actually doing is we're comparing our population to the whole country. So I like to say, if you took each of our counties and put them on the continent, this is how many doctors they would use. This is how many they would have. And so then I compare the number we do have with that number, and that is the shortage.
So it's sort of like compared to the mainland, but it's also very specific to a certain area and the kind of people who live there.
Right, because they take into account all our health factors, the age range, the ethnicity, the insurance coverage, the diseases. But it's still just a guess. And I wouldn't say that the average US population uses the appropriate amount of services. Sometimes we don't use as much as we should, like perhaps in psychiatry. Sometimes we use more than we should in some specialties. So it's not the ideal number, it's just a number to compare it to.
Does that take into account our geographic isolation? Because there's not really a comparison for that on the mainland. We don't have access to be able to drive. I can't drive to Queens.
Yes, so there's two numbers. So if I just subtract the doctors we have from the doctors that we need, we get 509. So that's how many doctors short if we put the whole state together. But if we look at these geographic differences and I subtract out any overages on a neighbor island, so maybe we have extra radiologists who can't take care of the flu, then we come out with 820. So I don't say any of these numbers are right, because right now we have about 250 openings. And we heard 15 of them are at the inpatient service that you run. So if we had a jumbo jet full of doctors come and land, all licensed and ready to go, we could only employ 250 of them today.
You know, Claire Anderson, you hear all this, does it kind of freak you out a little bit about what you're heading into? It's going to be a lot of work.
Yeah, definitely a lot of work, but I think all of my classmates are very aware of the physician shortage and are up for the challenge, because I know that a lot of my classmates are even working now to try to address the physician shortage, even in small projects they're involved with at school, especially in the rural health tract at JABSOM. I think JABSOM does a really good job of telling us what the physician shortage is and areas in which we can help, even as medical students.
Give me an example of a program like that, a little more specific.
Yeah, absolutely. So JABSOM kind of has two ways of addressing the physician shortage, especially on our neighbor islands. One track is sending medical students to neighbor islands to train and get exposed to rural healthcare in hopes that they can encourage them to practice there in the future. And another kind of track that JABSOM works on is providing visibility to high school students and college students on our neighbor islands to professions in healthcare to try to recruit and expose those kids to professions in healthcare and ways they can get to medicine or a related profession.
Do you see that most of your classmates want to stay here? Is that something that's really encouraged and really developing there?
Yes, absolutely. More than 80 or 85% of my classmates are from Hawaii, and many of them from neighbor islands, especially in the rural health cohort I'm a part of. I think the majority of us are from neighbor islands, and I know a lot of my classmates really want to give back here, and they recognize the need, and so I'm hopeful and hoping I can provide a little positive light on the future of medicine tonight.
I'm sure
So
you will.
are they teaching you how to go to a neighbor island to set up a practice? Because the majority of us on the neighbor islands are actually having to be in private practice out of necessity. In Hilo, we don't have Queens to hire us as an outpatient. Queens has some outpatient practices. We don't have a Straub to hire us. So out of necessity, we're in private practice. Our hospital doesn't have the capacity to actually employ enough outpatient physicians to care for the population of our area. So as a result, we need those private practice physicians, and that's something that's not really addressed. Those private practice physicians are being forced out of business, and medical students and graduating residents aren't either taught to run a private practice or they're not interested in doing so.
And I said we had 250 job openings. Traditionally, half the physicians open their own practice and half go into employment. Now, let me ask Claire, do you know what it means to hang a shingle? Okay, so it's an old expression, but it means you put up a shingle, you write your name on it, and that's your business.
Okay.
So you see, they don't even know it anymore. So
Well,
it's
they don't know that term.
right, but a lot of them come out and want a job. And Michelle is right. The places where we don't have large medical establishments, like Queens is in North Hawaii, Kaiser a little bit on Hawaii, but not too much. But Kaiser is on Maui, HPH is on Kauai, Queens is on Molokai, Kaiser's on Lanai. So really, you could say the area that is shortest that you showed us is the one that doesn't have the jobs.
You know, it's just to sort of roll back a little bit, Dr. Mitchell, in terms of your first decisions you made coming out of medical school. I was kind of surprised to hear when you came out, you wanted to be employed as a doctor, and I don't know if the average person knows what that means. Basically, you wanted to work for a clinic or a hospital and just do your job, but you found yourself having to set up a private practice. Why was that necessary, and how hard was that to do?
It was hard. You know, so as part of our training, when I did my residency here on Oahu, they brilliantly sent us over to Hilo for some rural training, and we spent 2 months separated over in Hilo, and it turns out I loved Hilo. I just fell in love over there. And I've always wanted to do rural medicine. That's where my heart was. That's where I've wanted to do that since 8th grade. So I went into medicine with that intent. I didn't know where I'd end up. Turns out Hilo. When I was over there, I got excellent recommendations. I spoke with the physicians over there, and people wanted me. We had the patient panels. There were no job opportunities, and I didn't have the wherewithal to set up a practice. That was not part of my education. I didn't know how to do any of that. I didn't know how to manage a practice, how to file all of the appropriate paperwork, and how to actually
How to get paid.
how to get paid, right? Do the billing, how to actually comply with all of the government and local regulations, which are important for medical students or residents to learn if they're going to hang a shingle. So as part of that, 2 other of my co-residents and I set up our own practice because that was my option to go to Hilo, which is where I decided I really wanted to be and where I was really needed. And that wasn't my first choice, but I did it out of necessity and the need for the community.
And I'm sure the community appreciates it. Let me ask Dr. Bruno. Dr. Withy mentioned this very interesting phenomenon of where big hospitals are competing with the community in a way for primary care doctors. You know, how do you grace that? How do you handle that? I mean, are you like actively, you know, competing with the private sector? You make a pitch to a doctor like this and say, you know, hey, you can come to work for us, you'll have more money in your pocket, you'll have better hours, and you don't have to worry about all the paperwork.
I think, and everybody else can comment, is I think we're in the middle of a transition about, and Kelly, you probably know better than I think about 40-ish% of the physicians in the country are employed. And I think we're undergoing a transition from the solo private practices, and specifically in Hawaii is historically there were no large group practices that were independent. And so it's mostly onesie, twosie practices. So if you look at a field like vascular surgery, there's no large vascular surgery group in Hawaii. It's either solo practice, onesie, twosies, or you work for the hospital. So these kids who train on the mainland I just use vascular surgery because it's on top of my mind, do 6 to 10 years of training and come back, is most of them are seeking employment. And so I think on the supply side, most new grads are looking for the stability of employment. For some of the stuff Michelle talked about, is they don't want to be on call every third night. They need the lifestyle to be healthy. On the hospital side and the health system side, is we need the physicians to be more aligned than in the past. It used to be, it was very transactional relationship with the hospitals. You provided care, the hospital provided the place to provide care, and everybody did well. Yeah. Those days are changing because of just the payment in the community, payment transformation. So the alignment is needed. So employment is the easiest way to achieve that. You make it much more complicated when you're talking in a place like Hilo. So I think it's not so much that the health systems are competing against Michelle. I think it's just the market forces that are happening are forcing the hospitals to get in the business. I
want to go to a couple of viewer questions because, as usual, they're intelligent and questions that bring up a whole new subject. There are not enough doctors for workman's comp cases. Is there a way to improve this? What is going on with workers' comp? I get concerns about workman's comp all the time. I mean, Doctor, are you able to take workers' comp? It's a specific insurance company, right?
It's a whole separate insurance company than your usual insurance company, and the issue is it's complex and requires a lot of paperwork. So a lot of physicians decline to take it as a result of that. Some physicians will take it, as I do, for our own patients, but we won't take it for separate patients that are not our own. But so, yeah, that does become a big issue for patients.
Workers' comp, you probably don't.
Not yet.
But is workers' comp, what happens if someone shows up with a workers' comp injury at Queens?
We take care of everybody. So to be fair, is what Michelle said. When I was formerly in private practice, is workman's comp is extremely complex, and you have to know how to do it to get paid. And so for private practice docs, it's just one more barrier to providing care. So it's just extremely complex.
Although there are groups that do exclusively that. Right. So yes. They know all the paperwork, they know who to refer to, they have it down. And those are probably the ones that do it best.
Are there enough?
No.
Okay.
Are there enough of anybody?
Well, that's what
they're busy taking care of patients with chronic medical conditions. Yeah. Everybody's busy.
Mm-hmm. Okay, so, would that together with the comments you were making about we're in this transition period, transition to what? I mean, is there one big thing that's going to change, or is it a lot of little things that are changing all at the same time?
Well, if the system continues the way it is, all our physicians will be employed in groups because that's easier to manage. It's easier to manage physicians in groups. It's easier to pay them salaries than to necessarily work with the onesies and twosies and have them do. The way the paperwork is now, it's very demanding.
You know, we talk about onesies and twosies.
Yes.
Just to get it clear, that's the doctors I went to when I was a
onesie.
She's a onesie,
right, exactly.
I've been called worse, Kelly.
And if I joined her, we'd be a twosie.
Okay. All right, so but that community-based guy on the street corner, the doctor with oftentimes the spouse as the office manager, yes. Is that gonna just go away?
Well, that's a fear. And the problem is 20% of our country is rural. 20% of the people.
So that's a rural phenomenon now at this point.
If we lose the onesies, twosies, there's nobody to take care of the rural population. You know, probably if you're in Honolulu, You can go to Kaiser, you can go to HPH, you can go to a large group, but if you're in Hilo, you can't. So if we lose the onesie twosies because they can't survive with the current state of payment reform or whatever the reason, or they want to be employed or they have too much debt, then we're not going to have anybody in Hilo to take care of people.
So, Claire, you mentioned that you're involved a lot in rural medicine.
Mm-hmm.
Does that mean you're on a course to want to be like Dr. Mitchell? You want to be a single practitioner out there, a community doctor?
I think a lot of us aren't quite sure right now on whether we want to be employed or private practice. I just know that
It's probably not good to fix in your mind what you're going to be in this world, right?
Yeah, since medicine is just changing all the time, but we do know we want to be in a rural place, and we'll do whatever it takes to do that.
Whatever system is there when you get there.
Yeah.
Okay. So in the rural places, but you're saying, you earlier said almost everybody will be working for
Well,
with
I'm
a
worried.
group.
I'm worried because the system is getting much more complex. So it used to be you would see a patient, you would write their note, you would bill their insurance. Now you see a patient and you have to fight to not have to turn away from them and go on the computer and document stuff. And then you have to click a whole bunch of boxes about whether you checked this with them or checked that with them or did this with them, and you have to report on this factor and that factor, and the labs you ordered, you have to report everything. You have to, death by 1,000 clicks, right? You have to click all kinds of stuff.
A million drop downs.
There you go. So it's more about the computer now than the actual patient. So, and that's just the beginning of it. Then there's prior authorizations. So have you gone to the doctor and had to get an x-ray of some kind or
Sure, I'm 63 years old. I've had
So my father went to the doctor and said, I've had the worst headache of my life. And this was a neurologist. The neurologist could not order a scan of his head. The neurologist said, it'll take me a week or two with the prior authorization. Just go to the emergency room.
Wow.
Just go see him.
Yeah.
That's the only way he could. So you have to fill out papers, but then we're not done. Then you have to bill, and then you have to fill out these extra things. And then we were talking tonight, and then you have to check your list of patients and make sure all your patients are on the list so that you get paid for all this. So it's very complex.
Yes, just another question for you on this topic. I'm convinced that insurance, health insurance, and professional insurance, that probably means like malpractice and stuff, are the biggest reasons that docs nowadays are all forced to work for large employers, limiting their options to larger metropolitan areas. Self-employment is not an option for docs these days. There's a couple of questions in there, but I mean, how big a problem is it? We were talking before about multiple insurance carriers and, is the insurance environment changing a lot? Is that kind of one of the big things that's happening?
I think, at least from the perspective of Queens, is we're actually trying to partner more with the health insurers in trying to take care of populations of patients. And so again, this need for...
What does that look like? Can you describe what does that mean?
So I think in the past, the question was when you negotiate with the insurance company, who ends up, with the better piece of the pie. I think, at least locally with the big insurers, we've realized that it's in this interest of both the health system and the insurers to work together. And so I've actually had a positive experience over the past couple of years trying to work with the insurers.
You just said when you negotiate with the health insurance.
Mm-hmm.
She doesn't have any power negotiating with the health insurer. Most of the doctors in private practice they're given a contract, you can sign it or not.
Fair.
If you don't sign it, you're going to have a difficult time of it because you have to go your own way.
Talk about your relationship with insurance
That's
companies.
been the issue, is our payment model for primary care specifically, which means family medicine, internal medicine, and pediatrics changed in 2017 across the board, and we no longer get the fee-for-service that Dr. Withey was just explaining, which fee-for-service is a direct exchange monetarily for a service, which hopefully in medicine is an exchange of money for brain power. You get to understand what's happening with you medically and hopefully get some relief and treatment for that. But no longer is that the case. And here in Hawaii, our major health insurer has changed to what they've called payment transformation, which means that the physician in primary care gets a flat fee per month or a capitated payment.
For each patient.
for each patient per member per month. And unfortunately, that capitated payment is the same no matter what service we offer the patient. So in primary care, in Hilo, where I try to offer a large number of services due to the lack of other clinicians in my area, I don't get paid any more than somebody who refers those services out.
Let me just ask though, is that amount per patient different depending on the particular needs of the patient at all? Like, does it say, oh, this is a patient that's got a history of diabetes and obesity and maybe mental illness? Do you get more for that person than you would for a healthy 35-year-old guy?
You're supposed to.
No. When I participated, which I no longer participate in this payment model because it was not viable and physicians were getting run out of practice where I was.
Mm-hmm.
So, but when I was doing that, that model did not pan out, and they pay a flat fee based on the insurance. So, the Medicaid gets a certain rate, the commercial gets a certain rate, and the Medicare gets a certain rate, and that's my understanding how it is across the board. And the average rate per member per month is $24. So that's average, but we get as a clinician to take care of all the preventative, acute, and chronic illnesses for you as a patient.
What effect has that had on your patients?
Well, unfortunately, for a lot of the patients, what we see is that the clinician is no longer able to provide as many services. The clinician no longer wants to front the money for things like a strep test, which we have to pay money for, or a pregnancy test, or a flu swab. And what happens is the clinician no longer purchases those and instead refers those things out, or tells the patient, I don't have any acute appointments available, go to urgent care. So across the board, it's not really actually saving any money in terms of medical dollars.
It's not saving money in the big picture.
That's correct.
But it is for the payer, for the insurance company.
No.
You don't think it's saving them money?
No,
either?
they actually released a study that was published in a major medical journal that showed no savings. It showed no increased costs, but if you read the study, it showed that payments to primary care decreased. The cost of primary care went down, but the cost of ancillary services or outside of primary care increased.
Okay, I'm going to try and we are getting a lot of calls, and I want to just kind of go through them as quickly as I can, and we'll sort of have a lightning round, so whoever wants to bite on a question, just bite on a question, okay?
Okay, where's the button?
Right. Nobody's going to want to push the button. Caller is a physical therapist on Maui. His observations are patient approvals are so hard to get, it makes it difficult to run a business. Reimbursement is 30% lower in Hawaii than on the mainland. He is aware of a cardiologist who is losing $230 per pacemaker. Does that make sense? Does this all line up with
Well,
what you're...
of course it doesn't make sense, but yes, it's all true.
Okay, I
And
didn't mean
that's the
sense in that
problem.
way,
That's
yeah.
exactly what Dr. Withey was trying to demonstrate. You know, when we don't get reimbursed fairly here, we can't attract physicians. All of the physicians here are practicing here because they want to be here. Claire wants to be here in the future. But if she can't afford to pay her student loans, if she can't afford to have a place to live and eat once in a while, probably every other day, then she can't be here. We want to be here. We're here because we love it here. And everybody who's practicing medicine in Hawaii right now is on a medical mission. Nobody is here getting rich, and most of us are actually losing money.
Let me ask, though, this question, though, and maybe Dr. Bruno or Dr. Withey can answer this. Reimbursement is 30% lower in Hawaii than the mainland.
Yes,
How could that be possible? Everything costs more here.
that's true.
So why is it? It must affect Queens,
I
right?
think the history of our health insurance is different in that in some ways our Medicaid pays better than other states. It's our commercial that pays lower than other states.
And is this a function of HMSA having a near monopoly for so long?
I can't 100% comment on that. I can only say that
You're in a medical school. You can say anything you want,
I
right?
can't say anything I want. I've probably already got myself in trouble. But if you ask me what is the one thing we can do to get the doctors we need, I say pay more.
But where's that money going to come from?
Insurance reimbursements. The insurance reimbursements in Hawaii are too low to sustain a medical practice. That is the problem. And no matter what we do to bring in new physicians, no matter what initiatives we have, no matter what the medical school is doing, what our state is doing, if we don't stop the exodus of the current physicians we have who are serving so well right now, then we are going to continue to have a crisis.
Okay, Claire, you still want to be a doctor?
Yes.
She is the solution.
Yeah.
You know, there were a couple of early callers we got. We'll sort through this. Both of them asked about, you know, satellite medical schools. You know, what's going on with that in the medical schools? It says, why can't programs be initiated in both Hilo and Maui? The need is greater on the Big Island, so shouldn't the first program be started in Hilo? I think that the first one's supposed to be in Maui, right?
Yep. So I know JABSM is working really hard to expand our medical campus to Maui, to both recruit more doctors there in Maui and also to give local kids there some visibility to a medical school and make, you know, healthcare profession seem possible for those kids. And so currently I think the reason why it is being placed on Maui initially is there's great interest from partners there, is my understanding, and I'm sure Dr. Worthy can speak more on why Maui is the location, but even if the need is greater on Big Island, Maui also needs help. And I think in time, the goal is to expand to all our neighbor islands, not just Maui. I think that's just one tiny stepping stone, and there's hopefully going to be many more.
Do you find that, I mean, you mentioned already that your classmates are all very committed to Hawaii, but what are you hearing about what life is like on the mainland? Have you heard from medical students who say, you're crazy for staying out there? There's a lot more money to be made somewhere else. Is that what goes through? You should do a specialty that's going to make a lot of money instead of that primary care stuff.
I personally haven't, but I know that is a reality for some people. But I think a lot of people have a true passion for primary care and for serving this population. And so maybe the grass seems greener on the mainland, but I think everyone is pretty dedicated to pursuing their passion here.
Okay, so
I think it's great to remember that, you know, these people have a passion and we should really cultivate it. And having the medical school expand to the other islands is really a great idea. But it still takes 7 years to train a physician. So even initiating these medical schools will take 7 years to get these people to graduate. I don't want to call them kids because you guys are awesome and adults. But, you know, it's still going to take 7 years to graduate a practicing physician. And on top of that, that doesn't guarantee, you know, a 4-year graduating medical student a residency slot, which we have not increased our residency funding nationally since 1997. That's a national issue, not a Hawaii issue. But even though we've increased our medical schools nationally, we have not increased our residency slots, which means that we may not have all of the space needed to generate these fully trained physicians.
Okay, I don't think I've had a show with this many questions before, so I just got to keep going.
You're going to have to have us back.
Let's just do it. We'll do another hour. What the heck? I remember hearing this debate a lot about tort reform and malpractice insurance, the cost of malpractice insurance. Is that a big limiting factor or a big problem here in Hawaii in particular?
I don't think relative to the reimbursements. I mean, I think, you know, tort reform 10 years ago, 15 years ago was a big subject, but our cost for malpractice is significantly lower than our health insurance, at least in my specialty. And so I think it's tort reform versus reimbursements. Reimbursements are a bigger issue.
I think they did a lot of tort reform actually a number of years ago.
Little bit.
A little bit?
Not too much.
Because I remember seeing all kinds of rules about how you can't bring a malpractice suit until you've gone through this claims panel and all this other rigmarole, right?
You were involved with that, right?
Yes,
Yeah,
I
was
can
gonna
tell you
say.
all about it, but
That's
I don't
right.
think you want me to.
Yeah, I think you're right, but you know, nothing personal about that. Okay, so okay, what kind of incentives, Dr. Bruno? What kind of incentives are being used to attract specialists to Hawaii? Is that part of your kuleana? Are you trying to?
Yeah, we actively recruit.
What happens when you recruit specialists from the mainland? What do they tell you when they tell you no?
Well, we have to compensate them fairly. So clearly, how much you pay them is an issue. making sure they have the right practice environment, that they have the supplies, the capital that they need. But we spend a lot of time to ensure that we have the right specialists. We have on call at Queens at any one time 22 different specialties. And one of our commitments is to make sure that we get those the call panels at the very minimum covered. And so it's a significant issue to recruit a specialist, a neurosurgeon. We've hired 3 neurosurgeons in the last year at Queens. That's a significant investment.
To Dr. Whitty then, but is primary care still our biggest shortage area? And in terms of, is it the most critical shortage area?
So it is the biggest shortage area because it is the biggest need. Because everybody needs a primary care provider, but not everybody hopefully needs a neurosurgeon.
I hope not.
But
Yes.
if you have a shortage of a neurosurgeon, that is critical in the time. If you need brain surgery, you must have that neurosurgeon.
How do you know if you need brain surgery if you don't have a primary care physician to help you determine that?
Well, if you don't have a primary care, you end up going to the emergency room
Right.
for your primary care, and he doesn't want to follow you all the time, but she wants to follow you all the time and know all about you. So that's not, no offense,
No.
not the best
So
care.
how do you get people to go into primary care instead of becoming a specialist when he's offering a mint to a specialist? No,
It's difficult. You have to have the passion.
really, so it's love.
It is. It's wanting to know everything about your patient and wanting to take care of them from birth till death. It's wanting to do the procedures that she's admittedly saying she can't do for them because it
Okay,
costs
that
more.
reminds me of something. Isn't our financing system just totally screwed up?
Yes.
Because I remember having a discussion once where someone said, well, the financials aren't lined up with the true need. So, for example, you mentioned, oh, I want to be a doctor who takes care of my patient from birth to death. Well, for the first 65 years, they're on one healthcare system. For the
Oh,
rest
no,
of their life,
they've
they're on
changed at least 10 times probably in
Oh,
those
okay.
65
But there's no incentive for the insurance company that's paying you when you're an adult for preventive care, because Medicare is going to pay for the chronic illness when you pass 65. That is, the financial incentives aren't lined up with the need. I mean, okay, so
It's a mess.
here's a question. This is going to open a whole nother can of interesting discussion. What's keeping Hawaii from having a system very similar to France? And I don't think they meant to talk about single payer. Is France a single payer country? Oh, I guess they all are, right? Where the physician can do the medical record keeping and bookkeeping from his own computer screen. I've heard that unlike our doctors, French doctors have minimal business overhead. Why is that?
Well, they probably all have the same electronic health record. We don't.
Fair.
Ours don't communicate with each other.
Like,
That's a
whose
big
don't?
problem. Theirs don't.
Mine
There
doesn't
go.
talk to his.
And mine doesn't talk to any of theirs.
Yeah.
Why not?
There's no national standard.
Oh,
Because we're capitalists and each of the companies are proprietary software.
so one company, one insurance company or one medical center will buy one system, another one will buy another system, another one will buy another system.
Although we're fortunate in Hawaii, 3 of the big health systems are on the same, so we can share records. But it's, like you said, the primary care docs, we don't get to see what they do.
But I mean, is the solution single payer?
Depends which single payer.
Okay, so government?
Well, it would have to be.
At the core of it, the government would have to collect the money and then pass out the money. But in terms of, they might have an insurance company that manages the system, right? So everybody's sort of getting really
Needs a
quiet now.
lot,
What-
needs a lot of work.
I think the problem that physicians in particular have with single payer, I think at the core, physicians all want single payer in terms of simplicity, and we want to take care of our patients. We want that part of single
The
payer.
simplicity of it.
Because then we won't have the huge administrative burden of understanding each different requirement for each different insurance, which maybe you don't have to deal with, but I have to deal with knowing each different formulary, each different prior authorization form, all these different things. So the simplicity we like. The trouble is that we have realized as physicians that what's happened right now is the government is regulating our medical system. And what's happened with that is they are doing so without physician input in terms of physicians who are actually practicing the real medicine. So by doing so, all the regulations are not working for people who are actually on the ground. And in fact, 2 members of the PTAC committee who advise CMS have resigned in protest of that the advisory committee who tries to give CMS advice.
CMS is
well,
the government
Medicare and
agency.
Medicaid.
Yeah, right.
They're the ones who are actually in charge of Medicare, our government-controlled system. And they've listened to none of the recommendations, and I believe that PTAC has given them 15 different recommendations over 2 years, and 2 of the small committee have resigned in protest of this.
So the result of that is you've got government regulations that are usually placed on the payers, right? The insurance companies and the
And on
government itself,
physicians.
and on physicians that don't mesh with reality.
So
Exactly.
let's play this out. If we were to have one payment, one payer, it would probably be Medicare, because that is national.
Medicare for all, right?
Okay, so let's say we have Medicare. Medicare is testing out different payment methodologies right now with primary care. There's 2 or 3 different ones going on, so they don't even know.
Minimum 5 to 7.
Okay, so 5 to 7 different payment modalities going on right now. So I think it would benefit us to have one for all, because then we would cut out a lot of the costs, which would be all the different insurance companies. And once I did a study of how many prior authorization forms there are, how many forms that neurologist would have had to fill out for my father's MRI, 1,000, just here with our limited number of insurance companies. So
we got like 5 or 6 insurance
kind of
companies.
8, kind of.
Okay. And there's 1,000 different prior authorization forms?
Yeah. But that includes different medications, different studies, different lab tests, different ordering physical therapy.
Do you have do you have different computers that you're talking to as well? When from your, like, does one insurance company have one computer system, another one has another one, or is it?
No, so I use one EHR, one electronic health system, and that's what I chart everything on. Now I have to log in remotely to our local hospital, Hilo Medical Center, where I do have access to see my patients while they're in the hospital and see their records. Now, if I want to log on to one of the insurance health systems to see whether my patients have met all of their quality metrics, I have to log on remotely to their system. And each insurance has their own system for that.
Okay. I want to come back, touch base with your excitement. I know you're still very excited about all this. How is it that you figure on coping with this? I mean, are you just supremely confident, or are you at least have some anxiety about what you're walking into?
Yeah, I think there's definitely some apprehension. We're all pretty anxious as it is, being in medical school, worried about exams and everything like that. But I think we are, thinking about it because we are very aware of the physician shortage and all of these challenges that they bring up. And so I think it's something we're thinking about, and hopefully we can contribute in a positive way in the future.
Do you have hope?
I do.
For the whole system?
Yeah, I do.
What gives you that hope?
I think it's seeing my classmates and seeing like the true, genuine passion that they have every single day in class. And so many of them are, dedicated to being a doctor and being the best they can be and providing the best care. And a lot of my classmates are super involved with the community. JABSOM is a very community-based school. So we have programs in many communities here on Oahu, on neighbor islands, and so my classmates are working on making connections, and hopefully in the future, things like electronic health records can connect in the same way.
They can figure it out. Dr. Bruno, in my business, in the journalism business, broadcasting business, one of the things that we do well and try and do is someone will leave Hawaii to go off to school on the mainland and maybe do 2 or 3 years at another television station somewhere else. Those are the ones we really want because they've gone and they've cut their teeth and they're ready to be professional on air. But when you look at a doctor who's gotten a medical school degree on the mainland and done a residency on the mainland, but they're originally from Hawaii, sure. Do you find many of them willing to come back, or do they just, is it possible for them to move back, or are they pretty much locked into their practices and unable to come back?
I think like most things in Hawaii is when we recruit, it's very relationship based, and we definitely look for a tie to Hawaii. And the JABSOM students, we would like every JABSOM student to come back. We don't offer residencies in any of the surgical subspecialties, And so if you're going to train, we're just talking vascular surgery, neurosurgery, you have to go to the mainland. And our ideal candidate is someone who goes to Jabson, gets trained well, comes back, and takes care of the people. So we definitely look for folks who have a Hawaii tie.
Okay, so there's somebody named Gill you need to talk to. He says, I'm a Jabson alumni currently working, this literally came in while you were saying this. I'm a Jabson alumni currently working on the mainland. My wife is also a physician. We would love to come back to Hawaii to work, but the difference in pay is just too great. Add that to the higher cost of living.
Yep.
Come back, Gill.
Please.
But that's exactly what we've been saying. And you know, you can't, no matter what aloha we offer, we can't compensate people fairly here in Hawaii at the rates we're being reimbursed. And that means that people won't come back. And that doesn't mean people are trying to get rich. Doctors here aren't getting rich. Doctors are just trying to make a living. And when we're not even getting compensated enough to pay for our practice, so what's happening is practices are closing and people aren't able to stay in business and they're being bought out by larger companies. And if there's not a larger company available to purchase that practice is forced to close, which is happening on the neighbor islands in particular, then that community is losing physicians. And no matter how much Claire wants to go to a neighbor island, if she can't pay to live, she needs to eat. She needs to pay her student debt. And all of those things need to happen for her to stay here. All of those things need to happen for Gill and wife to arrive here. And as long as we don't have the appropriate compensation and get paid 1/3 to 1/2 of what a physician can get paid on the mainland, people will not come here.
So it's that dramatic. Why is it so much? We talked earlier about basically the insurance reimbursements being lower, which doesn't seem to make any logical sense other than it's a monopolistic kind of thing. But you know, what's the solution to that in terms of, is there a role for the local government to play or the state government to play, or is there anything that can be done about that?
Well, I think it's historic. So in Hawaii, we have the Prepaid Healthcare Act, and it gives us a very high level of insurance. You probably heard about Obama bronze level and silver level. Ours is like
Gold.
double platinum.
Yeah, right.
No, it's diamond. It's way up there. We have amazing insurance, and we've kept the costs down over time. So I think it has to do with that relationship. The insurance companies have to provide a lot of service for probably a lower premium, definitely a lower premium than would be for that level of service. However, as Michelle said, if someone, so she's only paid $24 a month for seeing a patient, but how much does that patient pay in insurance? $500. So, you know, where does the rest go? It goes to medications. They're just phenomenally expensive now. It goes to procedures. It goes to the insurance company. It goes to managing all those forms that had to be filled out.
And also, just so people get it, insurance companies have to plan for the risk of all of their clients, right? So they do need to keep money aside so that that person who doesn't get sick is going to subsidize the person that does
Right,
get
so
sick.
for $500 a month, you might cost them $10,000.
Right. Okay, another big issue that we haven't talked about is they're asking about, what's the term I think it's called, scope of practice. There's a scope of practice debate, right, which is, what about alternatives to MDs, right? So a couple of questions. Why are RNs not being used more for primary interviews of patients? I've noticed a lot of clinics have released or failed to hire more advanced practice nurses. I prefer to have my medical follow-up with an APRN. And I know that the big issue was the nurse practitioners. How are we in this state with allowing nurse practitioners and other folks who are not MDs support the medical system?
They have full scope of practice here.
So that Hawaii is one of the states where they have full scope of practice.
But keep in mind, they only have 500 of supervised clinical hours. And
What does that mean? I'm sorry.
so they do 500 hours with patients with a supervisor teaching.
Oh, this is the training period.
The training period,
Okay.
yes. So probably the shortest training period for a physician is about 20,000 hours. So the differences in training are significant, but also the physicians are trained to do the procedures, take off a mole, even in the office, you can do gynecological procedures. There's a lot of procedures that doctors are trained to do that nurse practitioners aren't trained to do. Now, you heard earlier, Dr. Mitchell said that she's not going to do a lot, well, not you personally, I don't know, but the doctors will probably not take the time to do those procedures because they're paid one payment for the patient per month. So we're losing those. But in Hawaii, I think we have a fairly collaborative relationship, and we have a lot of practices. I don't want to say a lot. We have some very well-run practices that incorporate the APRNs and the physicians and community health workers, RNs, psychologists, and really work well together. And that's the beauty of medicine. If everybody is working up to the full scope of practice, so the highest level of their training, then the doctors wouldn't be pushing all the buttons. Mm-hmm. There would be help by somebody who knows how to perhaps take notes for them, which is happening a lot.
Which involves a bunch of people that aren't even in Hilo. Right?
That's true. I actually do use registered nurses in my practice to help me see patients. They do an exceptional job. The patients love it. They do a lot of patient education. And like Dr. Withy said, everybody should be working as a part of a physician-led team. It's very important that we all work as a team. The education tracks are different. We learn, we're in medical school, they're in nursing school, and we do learn differently. And we should all work together for the patient, and that's really important.
We also, just to jump in on that, so the team-based care, 100% buy it, that's
Beautiful.
where we're going. We actually struggle finding APPs, so advanced practice providers, either PAs or APRNs.
Okay.
For the same reason we have trouble with doctors is...
Too many initials.
So advanced practice providers, so the APRNs, the advanced practice nurses, or the PAs, the physician's assistants, is we don't have a physician's assistant program in Hawaii. So there's one...
We do now.
We now. Oh, I'm sorry, you're right.
Kona.
In Kona.
Yeah,
we
they
have
just started
University of Washington, right? Is that?
Medics,
Yeah.
The University of Washington came to Hawaii to train people
PAs.
here.
Right.
Yeah.
Talking about we need these folks, and we just don't have enough of them. And so the same issue with physicians we have is we have postings for over a year for advanced practice providers.
Oh, see. So it's not a magic bullet.
It's not a magic book. We don't have enough of them.
Go ahead.
And I was just going to say, I think one of our student groups on campus, the Family Medicine Interest Group, is putting on a huge study right now, an assessment, interviewing students, educators, and programs that exist on every single neighbor island, assessing what is working well in recruiting students into healthcare professions, as well as what are some challenges. And I think it's a great response for them to not say, like, this is how you can go into medicine. The whole purpose of the program is to give visibility to all healthcare professions, including medicine, but also the nurses and the...
Actually a good point, because one of the things that you reflected in your report was the idea of having the health academies out in the high schools so kids start getting a sense of what's available. It's interesting to me that you're talking about these advanced practice folks probably could be working a lot quicker through the training than someone who becomes a full MD. Is that correct?
Yeah.
And again, this team-based model of...
And it's probably a pretty good job.
Pretty good job.
I think it's a pretty good job.
So people who are out there thinking about medicine and don't think they can become a doctor.
Right. There's so many options for them.
Cool. Okay. This is a very nice comment from someone. It says, there's clearly a physician shortage and maldistribution in Hawaii. However, it's incorrect if the impression is given that healthcare is poor in Hawaii. The Commonwealth Fund produced report showed Hawaii is singular in its ability to provide higher quality care with longer life expectancy at lower costs than every other state in the Union.
Is
that true?
That is true.
But your
How
show
are we
would be
doing
a lot
that?
shorter.
So how are we doing that? I mean, what's great about our system here?
Well, we're healthy people to start with, and so we do live longer. What are we doing?
Our lower costs, our reimbursements are low.
Oh, so the doctors are
Right, I
stuck.
mean, it's right there. Our reimbursements across the board are low, both locally and federally. Our Medicare reimbursements are actually the lowest, which we're at. But right now, we're pushing to increase our Medicare reimbursements, because when our Medicare reimbursements are at base, when we're at the highest cost of living, if not the, we're one of, if not the highest cost of living in the nation, then that's a big deal.
Claire, we're kind of running out of time, but I'd like you to finish by answer this question. What percentage of the students passing through JABSOM are from Hawaii and likely to practice in Hawaii? That's the base of the question, but you know, how excited are you about the idea of these friends you're with becoming doctors with you and moving into this community?
Yeah, I'm really excited because there's so many programs that JABSOM has in effect, allowing students to train. Like I trained on the Big Island last year, and I'm hoping to train either on the Big Island or Maui next year. And I'm speaking to all my classmates, some of which are from neighbor islands and have been following these programs too, and they say to me, I can't wait to, you know, work here, and I can't wait to refer my patients here on the Big Island to you on Molokai. We're already kind of dreaming about something like that. And I think I just find a lot of hope in my classmates who, you know, say they want to practice on neighbor islands because of the visibility that JABSOM provided them to travel to neighbor islands.
What's the core value, though, that you're expressing by choosing that?
Of choosing a path in rural.
What's the core value? Why do you want to do that?
I think it's because all of us here in Hawaii, Hawaii is such a small place. I think we all have ties to a rural place or a place in need. Yeah, we have family, we have friends, we've grown up there.
Thank you so much, and thank you all of you for joining us tonight, and we thank our guests, Dr. Kelly Withey, Professor of Family Medicine and Community Health at the UH Med School, Dr. Michelle Mitchell, who practices family medicine, and thank you for that on the Big Island, Dr. Rick Bruno, emergency doctor and vice president at the Queens Medical Center, and Claire Marie Anderson, second degree UH medical student. Second year. Next week on Insights, the minimum wage. Is the legislature going to increase it this year? Please join us then. I'm Daryl Huff for Insights on PBS Hawaii. Aloha.